Miami, and he's heading a large group of intensivists. He's in charge of education of the critical care residency there as well, and sleep study. So welcome here to Kuwait. My next speaker doesn't need an introduction, because I used to know him when I was still thinking of critical care. So Prof. Jean-Louis Vincent, who's a well-known and currently professor in intensive care medicine at the University of Libreville in Brussels. He's intensivist and he had the World Federation, the World Federation for Critical Care, and he was the head of the Critical Care Society at the European level as well. I will take long introducing you, everybody here and the audience know you very well. Prof. Alison Fox, who's from McMaster University, critical care specialist. She had the critical care response team and the director of medical education at Hamilton Health Science. She's also scientific director of Sepsis Canada, a nationally funded research network. So the best to be here among us in the morning to discuss those questions who are coming soon. She's the chair organizer of the committee of the 17th World Congress of Intensive Care that will be held in Vancouver. So maybe we'll invite you from now to join the World Federation in September, Vancouver 2025. My fourth guest is Dr. Richard Ferré. He is the head of intensive care department of Vall d'Hebron, I'm not sure, from Barcelona, so Spain. And he's also have a great interest in, he's a trialist, and he has a great interest in sepsis. He did the SODER research group at the institution, and he had several research networks and like CYBERS, sepsis, and EGS. So he's very popular with his field and interest in sepsis as well. The last but not the least, it's my pleasure to introduce Dr. Ashraf Al-Koufi, who is trained as pulmonologist in critical care from UK. He's been working in Dubai ever since, had several critical care units, and he's leading critical care education as well as in infectious disease. So welcome our audience. Maybe we'll start with the question that we share them with all the speakers that you see. I thought they are challenging questions, and myself, I don't have any answer to those questions that I shared. Maybe we'll start with the World Federation. As we said, an ounce of prevention is worth about the cure. Do you think, as we started the sepsis campaign, we managed worldwide to control sepsis and reduce septic shock mortality?
So, is it the time to answer? 30 seconds, maybe?
Yes.
Okay, good, 30 seconds. So my answer, number one, thank you so much for the invitation, for allowing us to be here. So in my opinion, the short answer is no. The long answer is to be a little more elaborated, and I'm sure we'll have more opportunities here. I think we've done something, we advanced in the prevention and management, especially the knowledge of people about sepsis. So more people know now what sepsis is than before, but certainly we're far away from controlling or preventing sepsis around the world. So, short answer. Next.
Anyone from the speaker here wants to comment? So I'm going to
debate that people know about sepsis. I think we have some problems. We've got some data coming from Canada that in fact, we don't train physicians about sepsis. We don't train other healthcare professionals about sepsis as well as we should. In my own example in Canada, out of the 64 specialties and subspecialties across the country, only 10 mention sepsis in their training programs, mention the word sepsis. So I think we have that problem. I also don't think we have as broad a public awareness of sepsis, what leads to sepsis, nor how to prevent it. And as we start to see in the world challenges around even getting the vaccines that we know prevent childhood sepsis, I think we're going to see, unfortunately, even a rise in incidence in the next little while.
I think it has been several improvements. So awareness is higher. We have reduced time to antibiotic source control, vasopressors in certain way. But the frustration is that this is not standardized. And when you look to the improvement in other time-dependent diseases like myocardial infarction and stroke, the difference is huge. And it's difficult to understand why, because we are facing the same problem. We need to organize our system to provide early treatment, the same like myocardial infarction and stroke. And they have done very well in standardizing everything and to reduce organizing the hospitals and the system to allow patients to go for therapy very fast, but not for sepsis. I think the reasons are multiple. It's very difficult to recognize. We cannot organize this in pre-hospital care. It's difficult because maybe we are over-alerting the population, thinking that every infection could be sepsis, etc. There are many reasons. But the reality is that the other conditions that are time-dependent have huge progress in the last years. And for sepsis, we have some improvement, but not the same.
Perfect. So maybe we'll move to a second question with your challenging comment, which was published, Dr. Jean-Louis Vincent, the end of all size fits all. Do you think the emerging technology in AI and machine learning are still away from rapid biomarkers available, test stats available at the bedsides to make the diagnosis as early?
Well, there is a lot to say about it, and I'll speak about it tomorrow and the day after. But indeed, sepsis is not a disease. We should not try to see sepsis everywhere. Go back to the previous question. That would be a mistake, and some of our colleagues want to emphasize sepsis is everywhere. There are so many deaths from sepsis every day around the globe. But if people do not realize what this is exactly, they will lose trust, they will lose confidence in what we say, and we lose credibility. So, for your question, we have made too many studies, too many trials, where patients were enrolled only because they had a bad infection. That's what sepsis is about, after all. A bad infection with organ dysfunction. And these were very heterogeneous patient populations, and people want to do to apply vasopressor therapy for this mean-arterial pressure versus that mean-arterial pressure. Of course, these trials did not show any difference between the two groups because the populations were too heterogeneous, and also because the target was mortality. And mortality is not a very good endpoint for a trial because it is influenced by many elements, including the comorbidities, the past history of the patient. And also at the end, to make it short, at the end there are also some ethical decisions. For one patient, the relative will say, oh yeah, you need to continue to do everything, and the patient will survive. But from others, you will say, no, that's too much for my father or my mother, and that will result in a fatality. So we have too many negative trials oh, we should not say negative. No, I say negative, okay? Negative trial. No difference in outcome between the two groups. So the future is very different. In the future, we will realize that we need to have a personalized approach. We need to look at the number of variables that will characterize the patient. Of course, it is not easy, but biomarkers, a number of things we measure, can help us to identify phenotypes, subphenotypes, and this could result in targeted therapy. It may not be the same at the beginning of the sepsis episode and further away in time. So that's where artificial intelligence will clearly help us to identify these patterns, and it will help us to get into personalized medicine, and one day, well, not there yet, but one day precision medicine. We must learn from oncologists. Oncologists sometimes don't know what the source of cancer is, and yet they can treat patients on the basis of a particular signature. We will do the same in sepsis. I'll stop here.
Because there is more challenging question, and I'd like to hear from others of them.
I agree with Jean-Louis' comments, of course, but I think again it's another hypothesis, because the hypothesis 40 years ago, the hypothesis was that sepsis is a dysregulated whole response to infection. If we monomodulate sepsis, we are going to treat sepsis and we're going to improve sepsis. And this hypothesis has been wrong. We have been working in that 40 years and has been wrong. Now the new hypothesis is that if we are able to identify subphenotypes, subphenotypes, we will find a therapy, which I am in favor, and I'm working on that, but there still is an hypothesis. So I think, yes, this is the future, but again, it's another hypothesis, so the first one we failed.
Yes.
I'll just make a quick two comments, one of them on the technology, the artificial intelligence, and the machine and deep learning, and its effect in our clinical practice. The concept, of course, is very intriguing, it's very interesting. But as we can see, the final decision is a clinician's decision. So all those technologies are collecting data to help you to make the right decision on the right time to treat the patient on time. So yes, this advance will definitely help us, but the final decision will be taken still by the clinician. So if we are not able to access this data on time, interpret the data correctly, then our decision will not be correct. Come to the second part about the biomarkers. We've been about the rapid diagnostics. We have done a lot about that. We have many multiplex PCRs which are helping us very quickly, but we are talking about the bedside biomarkers. Something which is like, for example, the lateral flow testing for the aspergillosis, but that's not a very good example, but I need something like that, which will give me a battery of biomarkers at bedside. Some of them might be diagnostic important, some of them may be prognostic important, some of them we use later as the patient response as well. So definitely if we combine this with the doctors becoming aware of how the system is working, that will definitely improve our decision making and improve the outcome. And as Professor Benson said, it's difficult to talk about mortality because I can't control the infection which caused the sepsis, but the sepsis is like a chain reaction. It's going in its own. It will still kill the patient and cause multi-organ failure even if you control the source. So we should look for a different way of assessing our septic patient response to our intervention.
Okay, let's move to the third question, which is most of the audience here, I think, eager to hear because we can stay here, talk about new technology, but when they come to the bedside, they still have this challenge. So how much fluid and how much vasopressor is enough at the bedside when the patient goes into severe vasoplegia
and he is or she is in severe refractory shock.
I remember, and maybe some of my other colleagues around the table remember a time when we didn't give enough fluid and we used too much vasopressors and we ended up having more limb loss and we had more. So I think this precision approach that everybody's a little different in how much fluid they need, we need to adjust. How much vasopressor we need, same thing. I'll talk a little later this morning about some of the non-adrenergic vasopressors that we need to consider that may help balance the use of things that are really meant just to squeeze, to try and close down the blood vessels to preserve those internal organs, but it may not to be beneficial. I think what we're missing in our therapeutic regimen is the translation of what we know about the physiology. There has been a huge focus on the inflammatory response to the neglect, I would say, of the other part that goes along with this, which is the coagulation response that goes along with it as well. We're starting to learn, but we focused so much on the inflammatory response, we've neglected the other things that causes the poor perfusion of every organ, which is the clotting in the vascular system. And I think we need to balance both of those to create precision. I'm going to get back to something that Jean-Louis said, though. I'm going to disagree that sepsis is not a disease. And the reason I'm going to say that is twofold. First of all, oncology is a disease. It's heterogeneous. It has individual responses. It has individual organ dysfunctions depending on what it is. And more importantly, the people that fund our research, who change our policies, don't understand syndromes. They understand diseases that cause problems. And unless we start to cause or call this disease that we all deal with as critical care physicians a disease, we're not going to get the buy-in from the people who want to change this, similar to the way the cardiologists change their world, similar to the way the oncologists are changing their world. And so I think we need to be some consensus about framing this as a heterogeneous disease which is caused by infections and the body's response.
Yes.
Fluids, pressures. Let's be on that. We usually see the outcome that whenever we are excessively giving any of them, the outcome is always bad. But remember, the one who give more fluid and give more pressure is because his patient is not responding. So the patient is dying because of the severity of his disease, not because of the extra fluid which is being given or the extra pressure. Because if your patient responds to the fluid given, you will not give more. If the patient responds to the pressures which will be given, you will not give more. So the people who receive more are more likely to die, like the people who are dying on the best antibiotic. You feel the people who are receiving the best antibiotic are the people dying more, but receiving the best because they are more severe. So this is something which is important. So let's try to make it a bit easy and ask ourselves 3 questions. Does the patient need the intervention, fluid pressure? If the answer is yes, ask the second question. Will the patient benefit from the intervention? If the answer is yes, don't forget to ask the third question. Will this intervention harm my patient? Then you will know when to start, when to stop. Because one of the problems with the intensive is they don't stop till they arrive at the center. They need to stop a little earlier than this if they want to give the appropriate amount of fluid and the appropriate amount of pressure. And if the patient is not responding, find another way. Why the patient is not responding? It's not just to continue to give the patient the same and then complain. I have given them too much fluid, and then the analysis is telling too much fluid is killing more people. Why? Giving too much fluid because the patient is not responding. If the patient did respond, you respond. So it's very important to put the third question, when to stop because your intervention is becoming harmful.
Right, but again, I'm an R2 or fellow 1 in critical care, and I always pick up the phone in the middle of the night to ask you this question. When I should stop, at what number of vasopressor I should stop? So do you have a clear answer to the audience?
We don't have an answer for that, but we know for sure if you start to exceed, for example, a 0.5 microgram per kg per minute for norepinephrine, this means you are going nowhere. Even if the numbers will improve, the lactate will keep on rising because the tissues are hypoperfused. So you are osmotically changing the numbers, thinking that you are improving the patient condition while the patient is deteriorating. So it's very important to couple the intervention with the response and the function. If my intervention did not result in an improvement in the function, stop, because it is now harmful.
Okay, I think we have still 2 burning questions we need to ask here about precision medicine and novel therapy. So from diagnosis at the bedside to a novel therapy, how far we are from immune modularity and monoclonal antibodies and biological therapy for septic shock.
I'm running a phase 1 trial, drug repurposing study of IV DNAs for sepsis. It may surprise you, why am I using IV DNase 1? If you think about one of the things that we've demonstrated in the last little while, we now know that part of that clotting mechanism is because the neutrophil changes their phenotype in the bloodstream. They change from this phagocytic cell to a cell that releases their DNA into the circulation. We've shown that if you're in an ICU and you've got an elevated cell-free DNA and your DNase 1 levels are down, I can tell you you're not going to survive to 28 days by day 1 in the ICU. We repeated those experiments in animal models, and the timing is important, but we were able to demonstrate recovery of organ injury by giving IV DNase 1. We've had this drug for more than 20 years. We put it in cystic fibrosis patients all the time to break up the same thick DNA that's in the lungs caused by the bacteria that grows in cystic fibrosis patients. And so we're using that as one therapy. There's other trials going on that are thinking about replacing the stem cells and replacing the immune system that are starting. And then I think the last one that's coming that has been used but really not studied well is plasma exchange. And so I think there are some novel therapies. I think what we need to do better, though, is use all of the evidence that's coming about the heterogeneity, who's going to respond to which therapy, and apply it in a precision approach. I have to do the phase 1 trial. I have to make sure it's safe. But beyond that, we need to start thinking about who are the best people for whatever therapy we're planning. Similar, let's go back to, similar to the oncology approach. We know what the problem is, we're going to treat it with a precision approach.
Yes.
The paradigm shifts is that most of these new therapies that may come in the future is that they are coming with companion diagnostics. So the therapy and the diagnostics are going together in a pack. So for example, for angibotide, they have a companion diagnostic. They are planning to work with Roche, and they are combining with levels of soluble TREM, and they identify that those patients maybe are the responders, so they are going together the therapy with the companion diagnostic. The same for adretizumab, that is combining, in this case, 2 biomarkers. They are combining bioIDM, but also they also show that if the levels of DPP3 are also high, they have to exclude those patients, so they are going with 2 biomarkers together to target this specific subpopulation. So I think this is what we are seeing more and more, therapy with companion diagnostics altogether.
Are they coming soon? Like in 5 years, we're going to...
Well, they need the phase 3 trial because most of them are stopping in phase 2B phase, but probably this is something. But still they are having problems of funding. So it's not easy to fund these phase 3 trials, but I guess that this will come up
Yeah, but at least we need to focus on something. We know that sepsis, because of its broad understanding, the way it goes, it's not at the same stage all the time. So giving the same treatment to all the patients at all the time, early or mid or late, is wrong. We know that the inflammatory phase is hyperactivated early, and this is beneficial. I should not stop it because it is defending me. Why should I stop my inflammatory response while it is defending my system? But when that hyper-inflammatory response starts to attack my system, then this is the time to downregulate. So we have to differentiate between the phases and not to give all the treatment to all the people all the time, early and late, the same way, because at some time the patient is hyper-inflammatory, but that's beneficial. When that cytokine storm starts to attack your body, then you need to downregulate. You will go into a state of immune suppression. Then the situation of giving the same anti-inflammatory and immune modulating will become extremely dangerous. So if you don't know at what phase we are dealing with our patient, and this is by the help of biomarkers, by the way, we do have a lot. People thought that the cytokine storm is something related to COVID. I don't know from where did it come. Any septic patient is in cytokine storm. The only idea is we never try to modulate that storm response in any other patient except during the COVID time. So we need really to specify at what phase we are seeing our patient in order to personalize the treatment at that particular phase if we want to achieve success.
Okay, maybe for the sake of the time, I'll ask the last question. So till now, we are in January 2025. Sepsis to me is still protocolized, not personalized. So how many years it will take for the research in sepsis to have a personalized management for sepsis and septic shock?
I think we're on the cusp. I think we now understand the biomarkers. We've got to broaden our idea of where we're studying sepsis. Yep. We've spent a long time studying it when they're already in the ICU, when they've already got hospital-acquired infection. We need to move to that 80% that presents from a community-acquired sepsis. Let's chat again in 5 years, see if we've moved things along. We've done a lot of understanding in the last while. Give us 5 years.
All right. So in 5 years, so maybe we'll meet here in Kuwait and challenge those questions again to see how much we achieved. Because to me, as a senior intensivist now, it's been more than 60 years. Sepsis, I don't think sepsis or management of sepsis or the protocolized sepsis made a difference in mortality. And
actually, the changes in the protocols every few years tell you that what we do now tell us that we didn't know before. So probably in a few more years, the idea of fill the tank first, and then I think we should stop doing that. We should stop doing that. We need to know at what phase we are dealing with our septic patient, so our intervention will be more personalized. That doesn't mean that the protocol is bad. Protocol is good, but we need to know how to use it.
Okay, we'll have a time for 2 questions from the audience. Any question?
Well, in the meanwhile, perhaps we can emphasize that we all use some protocols for simple things, and nurses have many protocols for their activities. The question is, we're up to extend the protocols, and protocolized care, when developed to a too large extent, can be bad. Can be bad because it tends to consider that all patients are similar. Sepsis is not a disease. Sepsis is associated with many diseases. It could be a lung pneumonia, it could be a ruptured viscus, and the treatment will be very, very different. Even if we try to look at timing, we don't know in many cases when the lung infection started. Or we may not know exactly when the abdominal peritonitis started. So the time factor is not the same for everyone, and everyone has its own response. So what we clearly need is good teaching at the bedside. We started the Surviving Sepsis campaign in Brussels many years ago, 25 years ago. We started our first guidelines, and we tried to be positive, to give advice to the young doctor. The Surviving Sepsis campaign guidelines have changed, and now it's basically a literature review with a review of all our negative trials. So don't do this, don't do that. There is no evidence for this, no evidence for that. And how do you apply a protocol? No. We just say it for fluid, it may vary from one patient to another. For the dose of vasopressors, the optimal blood pressure will vary from one patient to the other. So what we need is good teaching at the bedside. We need to be trained. We need to be good clinicians. We cannot write protocol in an office before our computer. No, we need to be at the bedside. How do you become a good surgeon? You learn from experienced surgeons in the operating room. So that's what we need, good teaching.
Thank you. I totally agree. I'm always at the bedside. Come in and join me, please. Okay. Any other question from the audience? We challenge our panel quite good that none of the audience have a question for you. I think it's...
There's one over there.
There's one? Okay.
Yes.
David.
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 Oh, David. Take that.
Good morning, everyone. My name is David Koo. I'm from Melbourne, Australia, and Zig's Negative Trials Group, Jean-Louis. My question is this. Obviously, over time, mortality, we have the luxury discussing personalized medicine as well as functional outcomes and patient experiences, because over time, we have seen the mortality drop from 30, 40, 50% for septic shock. Now, in my own unit, 8%. We don't see death from urosepsis anymore. So I think we have made pretty good leaps in our care in septic patients. So I guess my question for you is this. When we struggle already to get enough power to demonstrate broad enough therapies for patients, when we have trials that have negative exclusion criteria, like for 40, 50 criteria, how do we actually have a power in a study to show this personalized precision medicine? Thank you.
You don't ask easy questions, do you, David?
I just really want to comment on the issue of mortality. The primary reason why we are seeing this kind of reduction of mortality, because we started to include less severe patients in our denominator. Every time you consider a 90/60 with a lactate of 2.5 as sepsis, who of those patients died? So when we started to put definition for sepsis, and we refined our definition for sepsis, we started to include less severe patients. Severe sepsis with multi-organ failure are still having the same outcome. Our intervention is better, yes, but we still have it's exactly the same like what happened with the ARDS. Once they put the new diagnosis, they said that the mortality reduced from this much to this much. But if you go to the older definition by 1976, when 50/50 and 60/60, that was a PF ratio of 100 or less. The mortality is exactly the same. So yes, our better understanding to the pathophysiology and the timing and what to do and how to do and when to do is improving the outcome, but it's not that much, not from 40 to 8%. The only reason I can see a mortality reduction of that much is probably because we are including much, much less severe cases in our denominator, so our mortality will look relatively small.
Okay, for the sake of time, I would like to thank you all for sharing your experience with us. I think it's a good beginning for this conference to start with such a debate, to make the audience hunger for all the presentation that you're going to share with us soon. Thank you very much.
Thank you.